Hi, everybody. Welcome. Hope you're just getting settled in here. We just kind of wanted to wait a couple minutes here. Make sure everybody's in. We'll start in about 1 minute here. So welcome. Okay, so let's go ahead and get started so we make sure that we are done on time. I want to respect everybody's schedules tonight. Welcome to your attention, please. Demystifying ADHD. I have Dr. Stein with me. He is the current president of Minnesota Society for Child and Adolescent Psychiatry. He is the clinical director of PrairieCare's medical office building and works with patients age 4 to 74. His practice includes clinic, partial hospital, and inpatient psychiatric work. Since Governor Walz placed the shelter-in-place order related to COVID-19, he has been a vocal advocate for the mental health needs of children, appearing on NPR, Twin Cities Live, and KS95 Radio. He attended UMN for a medical school, residency, and fellowship, and continues to row the boat as a Gopher fan. Additionally, he is part of the award-winning psychiatric assistance line and provides psychiatric education and support to primary care physicians throughout the state and expand access to psychiatric resources. Finally, and perhaps the most importantly, he is a father of 3 with 2 elementary age children. All right, I'm gonna give it to Dr. Stein. Dr. Stein, thank you for being with us today. Go ahead and take it away.
Thank you for having me, Melissa. Thank you for arranging this, and I'm really, really honored to be here. Go Hawks, go Storm. Congrats to the speech team. I saw that online today. Well done. And Integrated Arts Academy. Very cool. I was looking that up, and I'm really impressed by your district and its dedication to its students. I'm honored to be here. We're going to move kind of quickly, and I apologize for that. I really want to give kind of this overarching sweep on ADHD, what it is, how it's diagnosed, common conditions that have, that often get mistaken for ADHD, medication treatments, non-medication treatments. So we're going to move kind of fast, and I want to leave time for questions. I will stay available even if you don't. And I want to respect bedtimes are coming, end of the night is coming, there's a lot going on. So I hope everyone's in their favorite sweatpants and relaxed, and we will get started. And I will try to hold your attention as best as I can. I also want to say my colleague Anna Bollinger is doing this next presentation on the 29th. She's an exceptional speaker, and her topic, I think I'm going to watch it, Good Enough Parenting in Pretty Bad Times. So check that out. All right, standard disclosure slide. I just want to say, I do have a Western medical education, and sometimes this will skew the way I present things, and I'm aware of that, but I don't really come at it from an Eastern perspective. I'm aware of some complementary treatments, but really this is a more classic kind of Western medical presentation. So there's a lot of questions about ADHD. There's websites for parents, articles, specials on Netflix. There's a huge Adderall movie about the abuse of it, the use of it, the overdiagnosis. It's even like a featured episode on South Park. People are wondering, are video games terrible for my kid? Do stimulants put my child at risk for substance abuse? Are smartphones causing all of us to have ADHD? Probably. And so the goal of this lecture is to kind of clear that fog and get rid of the mysticism and kind of look at what the medical evidence shows. This is a really common condition. We all have children or know of children or who have family members, or we teach children or care for children or love children or adults who have this condition, and it's really easy to treat. It's kind of complicated to diagnose, and I want to kind of help make you feel more confident in it. And then I'm also going to give you some really good resources kind of as we move forward. So this is kind of what we're going to try and go through. Why is every diagnosis unique? What are the diagnostic criteria? How do we make a diagnosis for this? What treatments exist? How do you choose a medication? We talk about pharmacogenetic assays or gene site. What is that? What is this new thing I keep hearing about? A DNA test that tells me the right med the first time. What resources are available in our community? And I really love for you to ask questions throughout. There's a lot of material, so we're going to keep moving. When I started this, I remember being a kid in the 90s and 80s, and it was like there's ADD, inattentiveness, ADHD. Those were the hyper kids. And we've really combined the two diagnoses now to ADHD. So you don't really hear that ADD anymore. Both are called ADHD, with the kind of classic inattentive type being called ADHD inattentive type. So I hope that kind of simplifies, and we're going to talk about the differences as we go forward. So I just want to say this is, again, a really, really common condition. It's well studied. So prevalence at any given time is close to 8% of the population would meet criteria and is diagnosed with this condition. And about 4% of the population is actually being treated for that. So if you think about that, that's like 1 in 25 of us. That's pretty significant. So this slide, I literally use in all my lectures, and I think it's a really important slide. The field of psychology, psychiatry, these are really different medicines than potentially the kind of classic, oh, your thyroid's low, we see it on a blood test, that is indicative that you have low thyroid, we treat it this way. Our diagnoses are made based on these books that list symptoms, and if you have the symptoms, you meet criteria for the diagnosis, now you have it. There's ways to test for it, there's ways to check for it, but it's still kind of based on evaluating the person through questions, through engagement, through discussion, through lists, making the diagnosis. Yuri Bronfenbrenner kind of looked at how you develop, and I think this is really important. So you in the middle is your biology. It's kind of who you are. It's, were you born at 32 weeks? Were you born at 40 weeks? Were you born at 42 weeks? Did sadly mom drink alcohol while she was pregnant with you? Do you have an extra chromosome? Do you have an elevated IQ? Are you exceptional? Are you not? All these things. But all that biology of you then intersects with this microsystem of what's your family like? What's your school like? What are your friends like? In your religion, are you valuable? Are you not? In your workplace, are you proud? Do you have work that makes you feel strong or not? Is your neighborhood safe? Can you go out and play? Can you not? Then those things interact. Then you have the exosystem, this larger system, politics, education, government. What is valued? Kind of an exosystem idea that we talk about, and a macrosystem idea we even talk about is, back 50 years ago, 40 years ago even, the field of psychiatry saw homosexuality as a diagnosis. That has changed strikingly at this point, and it's abhorrent to think that that was the case. But those overarching beliefs and values kind of led to diagnosing what people are. So I just bring this up because I think that there's a neurodiversity and there's kind of a neuropresence of kind of who people are at a given time and how we look at diagnoses and how we look at illness in this field that is a little bit different than any other field of medicine. And so when you meet with a doctor, when you meet with a psychologist, the good ones, and hopefully all of them, are going to want to know about those other things going on, about your beliefs, how you see it. What is the expectation of your child? How hard is the school? What are the classes like? Because that can really help us identify what's going on, how to help, is this the right diagnosis or not? So anyway, moving along. ADHD is strikingly inherited. 75% of people with ADHD show an inheritance line, and that is similar to height. I mean, it's crazy. So like tall Scandinavians, which we are, a lot of people are, not me, in Minnesota, have tall children. And people with ADHD have kids with ADHD. It's quite common, and that's kind of the pattern we see. And often parents will talk about their challenges growing up, whether they were diagnosed or not. They'll often say, oh my goodness, this is what's going on with me. Whereas we go through criteria, they're like, that's what happened when I was a kid. So we often see that some parents already have this dialogue and already have this awareness for their children. There are some risk factors that can cause this, exposures in utero being the big one. Usually it's exposure to alcohol, tobacco, pesticides, or certain drugs that can cause this. What we see is that often the brain is underactive. The brain is kind of, I think of it as, if this is the normal pace, bump, ba bump, ba bump, ba bump, ba bump, ba bump, ba bump, the brain's going bum, bum, bum. It's a little bit slower. It's taking things in a little bit different. And we see that kind of the stimulation from dopamine and norepinephrine are a little bit lower. And that's really how we move to treat in a very different way by augmenting those agents when we talk about meds. These underactive brains can definitely be seen on EEGs. A reminder that these are kind of the stickies that get put on the head when we're looking for epilepsy or seizures. They also can show these brain waves. We do see slower waves that the meds then move to faster waves, especially in the frontal lobes, the thinking area of the brain. So why do we treat this? Like, what's the point? What's the point of treating ADHD? And what we see is there's a lot of issues with not kind of reaching your potential, not growing and maturing, getting kind of off topic easily, going in the wrong direction easily, and kind of things going in the wrong way. And so I think that it's something that we're kind of trying to get ahead of, that lack of thinking things through, that giving up due to frustration, that kind of impulsivity towards drug use and other things. Kids with ADHD often have less proprioceptive or awareness of kind of where their body is in space. They have more accidents. They're more likely to fall off the chairlift because they're not paying attention. They're more likely to get hit hard in football because they're not guarding themselves. So often it can lead to also some awareness of where you are. Then finally, alcohol and drug abuse. A lot of people with ADHD, due to impulsivity or a need for self-treatment or a need to slow down, will often kind of start to use substances as a method to manage, or they're more at risk to try them because they don't think through the consequences. So when we treat, we really try to avoid these negative outcomes. Other outcomes are kind of, if you start to really struggle in school and you're kind of on this trajectory and you come off of it, you can start to kind of develop a negative view of self, a negative view of your ability, a negative view of your ability to cope and do well and be successful. So all these things on your screen are what can kind of happen. And it can get dangerous. The unplanned pregnancy and STDs, that's about not planning ahead, not thinking things through. And so it's really something that we keep an eye on. Driving accidents, I have a lot of teens I work with who really struggle to drive without their medication because they lose track. There's so many distracting things nowadays, even in your car without a phone, it's very easy to get kind of lost and struggle. So we do see an increased risk of driving accidents for untreated ADHD as well. So for many of you who are joining, you may have children with these symptoms. And I think that you recognize them. And I can speak personally, I kind of talk about having kids in elementary school. I have one son with ADHD, and I have one who doesn't have ADHD. And my son who has ADHD, he struggles to pay attention. He makes a lot of careless mistakes on his work. He's easily distracted. He loses his things. And he kind of struggles in this way. He's my older son. My middle child, my younger son, it was striking when we did homework with him. And even though I have this education, I only knew my one kid. And I really saw how hard it was for my older son to listen, to pay attention, to follow those multiple commands. Hey, buddy, can you go grab your cleats, grab your jersey, and grab your helmet? And then he comes down with, his cleats in a water bottle. We kind of see this, whereas my younger son kind of is already prepared. He's thinking these things through. Also, that difficulty in playing quietly we often see, to the point that it's really disruptive for families, disruptive in the school. And so these things can be problematic. So when we look at the hyperactive symptoms, these are that was kind of the busy mind, and I think of these as the busy body. So we see a lot of kids struggling to stay seated in school. They get up quickly, they move quickly, they leave the classroom. Kids who are kind of always on the go, they have a motor in them, they just don't stop. Difficulty, again, engaging in quiet, chill activities, talking too much, interrupting, blurting out, and then a lot of impatience. And you can see kind of in a school environment, at least how we teach school, this really makes it hard. It also makes it hard when kids get older to stay focused, to pay attention, to do well on exams. I kind of think of these kids as they're kind of taking in a lot, and they can't always figure out what is the important things to take in and what isn't. So they do a lot of kind of playing with their environment and grabbing things and touching things and feeling things. And it can be really interrupting. So just to kind of go through the basics of the diagnosis, it can't be due to opposition or failure to understand the task. And I think this is where the differential, which we'll talk about, comes in. Not so much the opposition, but the failure to understand. If you have a exceptionally slow processing speed, but not ADHD, meaning you can't take things in very quickly, you may just not be understanding what's asked of you. If you have a central auditory processing where when people talk to you, your brain doesn't do a good job of turning it into information you can use, it's going to be really hard for you to do the task. While that looks like ADHD, that's not in fact the case. Then we kind of have these standard 6 symptoms from above, and then for older people, they just need to have 5. It changed years ago. It used to be you had to have symptoms before age 7, and now we say it's prior to age 12. I think this is really important because many of the inattentive young people are getting missed. And it's kind of like they're not disruptive, they're kind of sitting there, they're wallflowers, they're quiet, they're daydreaming, they're not part of things. But it's not really until middle school that we kind of start to see some of these aspects show up that are disruptive, that are problematic, that are hard. This has to happen in 2 settings. And this is a big one, and a lot of kids I work with, it's like mom and dad feel there's ADHD, but school is giving us a really different history. Or school is seeing a lot of problems, but mom and dad are saying, we don't see any of this. That's when we really want to kind of collect more information, collect information from the school, from the parent, maybe do some testing to try and understand why there is this difference in environments. But we really want to see those 2 settings of negative effect. And sadly, sometimes this can have to do with a history of trauma, history of being scared in certain settings, potentially bullying going on, easy distractibility, other things that could kind of be on the differential or alternatives to this diagnosis. And then the rest of this is kind of like standard, with the exception it does occur with autism spectrum disorder, which I think is important to know. So who makes this diagnosis? It would be wonderful if we had a quick lab test, a quick swab, something that could just quickly, like, boom, make the diagnosis for us. We don't have that. What we do have is the ability to do comprehensive structured and unstructured evals. And what I find is commonly pediatricians, psychologists, nurse practitioners are very dependent on your more comprehensive evals, including testing, whereas child psychiatrists, and I think it's due to the amount of children we see, and then in our training, we really have years and years of seeing children and building patterns, are commonly a little bit more comfortable based on an office interview and just collection of information from mom, dad, and teachers. So it really depends on the situation, but there's kind of not a strict and specific way the diagnosis is made. So we really look for a history, we look for comorbidities, that developmental review. The school history is really important, medical history is important. And kind of you can see when we're looking at our differential, it's quite extensive. There's a lot of different things that can kind of show up as ADHD. And I'm not trying to scare anybody. I'm not trying to make you think, oh my goodness, what if my kid has this other condition? These are just things that your doctor, your nurse practitioner, your pediatrician are thinking about when we kind of go through these. I'm going to talk about some of the common things that we do miss. And I think some of these as parents may apply to you, but also as educators, I think the educators, it's important that they hear some of these as well. Seizures, I'm not going to talk too much about that, but there's a very common seizure called an absence seizure. Just kind of your blinking eye kid who seems to space out for a few seconds at a time. And during that time, they're having this kind of absence of thought. And because of that, they can't stay engaged and they look very inattentive. And then they can often become disruptive because they're just struggling. They don't know what's going on. They're missing things a lot. And this is something for kids with staring spells in school. Very specifically, look and attentive should be checked on. Oops. Okay. So alcohol-related neurodevelopmental disorder. Many of you know this is kind of fetal alcohol syndrome. This is kind of without the facial deformities. And it kind of has to do with kind of periods of development during pregnancy where there is an exposure, and it cannot be a significant exposure. It just happens at kind of a precise time. That's why we want mothers to really not be drinking at all during pregnancy. Usually, this has to do with really an issue with kind of low distress tolerance, significant kind of impairment in social skills, and we see kind of academic issues, occupational issues, and also areas of other functioning. This often has a little bit different feel than straight ADHD, but sometimes these kids kind of start in the ADHD clinic and we kind of figure it out over time. We see that the meds are a little bit less beneficial. These kids need more support. They often need an IEP and then a lot of self-regulation training, not regulatin, my apologies. If this is something you're thinking about, I'm going to send my slides at the end of the day to Melissa. It's something you may want to look at, and this kind of guides us a little bit. But this is one of the top things we see is kind of on the differential. A lot of parents wonder, you know, my kid plays football, my kid plays hockey, whatever it may be. They've had a brain injury. Is that causing their ADHD? And I already talked about kids with ADHD, sadly, are more likely to have accidents because of that like kind of lack of proprioceptive or body awareness. So when we really look at kids who've had a hospitalized TBI or brain injury, we see that a lot of these kids do carry some inattentive symptoms. They do carry the symptoms of hyperactivity. These are often kids where it's kind of not present in family members. It's not present kind of across the system. It's like this kid is kind of doing okay, fell off the dirt bike, and then kind of has had struggles with focus since then. The good news is the meds are quite similar. They're often quite effective, and they help with some of the impulsivity related to this. We also will see that over time, these symptoms will get better in a way that not always, they don't always do with ADHD. So it is important if you're kind of had a TBI, you're treating for ADHD, to take breaks and kind of keep an eye on whether you need to stop the medication at some point or not. So executive functioning disorders. So I'm going to get it. This is when we get a little bit precise. And I just want to say that. So ADHD kind of is an executive functioning disorder, but there are some that are more precise and are not in fact ADHD. So sometimes when we're seeing kind of not responsiveness to medications, or we're trying to understand what's going on, when we kind of gather more information through neuropsych testing or an IQ assessment, we can see that kids actually have very high IQs. Many of the kids I work with ADHD are bright, they're intelligent, they're going to have a wonderful prognosis, they're going to do great, they're going to change the world. And actually their ability to connect the dots in ways that not everybody else does is going to serve them. However, certain kids, they have some abilities, but then they kind of lack maybe working memory, meaning their brain doesn't have the ability to hold things long enough to solve the problem or fix the dilemma. Kind of say the brain can't make sticky notes that it can use and then kind of crumple up and throw away. Cognitive flexibility. This is the idea that you can kind of be focused on one thing and then quickly shift to another. It's often tested by kind of, you have a kid looking at a deck of cards and they try and figure out the pattern of what cards are right. And then halfway through you go from saying we're looking at the color of the card to the suit and see how many cards it takes them to realize what the new pattern is. And that kind of getting stuck on something and struggling to get unstuck can be a very own dilemma that has to be taught and has to be supported. Finally, another disorder of executive functioning is inhibitory control, the ability to look before you leap. And while kids with ADHD struggle with this, at times there's kids where this is the only issue. So at times these are often more complex disorders. They're often multifactorial and there's multiple causes. And it is something that will show up on neuropsych testing, especially when kids are struggling with response to other things. You can kind of see there's different ways to treat this. And stimulants at times are effective, but at times are not. And sometimes we have to kind of dig back when we're getting our diagnosis wrong to try and figure out what the next step is in care. Central auditory processing disorder is another very common disorder on this differential. 5% of kids have this. It's this idea that kind of the noises come in, the words come in, the instruction comes into the brain. The brain doesn't do a really, really good job of kind of transferring that into something it can utilize or it can use. So these The other thing is the brain doesn't do a good job of kind of getting rid of the background noise. And I think a little bit of like, if you go to dinner in a really loud restaurant, I don't know what's down by you guys, what the taco place, oh, you have that new really cool taco place. I forget the name of it, right? Oh, Tequila Butcher. So you go to Tequila Butcher, you're trying to have a conversation, and somebody is talking at the table next to you, and the table next to you, and the table next to you. And you're finding it's just really hard to kind of hear and pay attention to what the person's saying because all this other information is coming in. So what you see is the treatment for this is not a stimulant, even though the child may look really inattentive. It's getting the kind of a right support in school, perhaps through an IEP or 504 plan that allows quiet, that allows time, potentially allows other ways to learn. So an example would be, this presentation I'm given, having the live captions that come across the bottom, so they can learn by coming in the ear and by reading. And then also practicing attentiveness and maybe working with somebody else. So processing speed disorders is another one. So I kind of talk about processing speed disorders. I want to talk about like Robin Williams. Robin Williams, I don't know if he was funny per se, but he was so quick and so witty, and he processed information so fast that it was hilarious the way he connected so quickly. That man definitely had ADHD. He did not have any sort of processing speed issue. I kind of joke that the opposite is like in New Jersey, people always have a quick comeback. And in Minnesota here, we're kind of like, okay, yeah, we take our time, kind of think things through. We have a little slower processing. This is not indicative of intelligence. I think of my buddy Tom in med school, who's an incredibly successful anesthesiologist. But man, that kid took a lot of time to take a test, a lot of time to study. He's just someone who needed time. He processed more slowly. So when we find that this is happening, we don't have to treat with a stimulant. We don't have to treat with non-stimulants. We treat with an IEP, making additional time, having learning strategies. Because if kids have really slow processing speed, and they only have that hour for the test, and their brain takes an hour and a half, they'll start to make errors. They'll start to give up. They'll stop learning because they just feel like they can't get through it. Anxiety. So this is a big one. And when I do consultation to pediatricians, this is a huge question they have. This kid is struggling. They're anxious, but they're also inattentive. Is that they're so anxious, they're so worried that they can't attend to things, or that they're inattentive and they can't pay attention, so they're worried about getting the work done. So this is a tough one. It often takes some time to figure out. Family history is really important, and getting to know the family is important. If you have a lot of ADHD and inattentive people in the family, that gives us some information. But also, if you have really anxious family members who struggle in this way, that also gives its information. This is a good way to collect from other people too. This one's interesting. Stimulants at times, I'll say it later, but the proof is kind of in the pudding. If there's really a high concern for ADHD, but also a lot of anxiety, treatment with a stimulant within a week, you should be able to see both the ADHD and attention improve, but also potentially see that anxiety get better as kids feel they can kind of unleash their intelligence. They don't have to worry about getting behind and having all these strategies that don't work for them. On the other hand, if you start a stimulant on somebody who doesn't have ADHD, commonly they'll feel more revved up, they'll feel more anxious, they'll struggle. So sometimes when the diagnosis is missed, it's also clarifying. It's helpful to kind of learn in that way. And of course, if there is anxiety, we treat with non-stimulants, we treat with therapy, we treat with built-in strategies, and there's a lot of different treatments, and that's a whole different lecture. So just kind of pointing out, these are a lot of the different ways that we assess, and there's a lot of these that work really well. And often, if you are going through this process with your child, they may ask you to fill out some of these. It is data collection. It is qualitative, meaning that it's dependent on the person filling it out. Often you want a couple parents and a teacher to fill out the rating scales. Often it's a good opportunity to kind of get some good information. These are combined with that clinical evaluation of talking, watching the kid to help us kind of understand what's going on. And really, sitting with a child in my office for a period of time, we can really get a good idea of what's happening. So anyway, A lot of times parents want to know, hey, do I need an MRI? Do I need an EEG? What else do I need to do? And usually we don't need to do a lot. Truly, there's a very rare time that more intensive testing is necessary. And so if we're looking at kind of a syndromic appearance of a child, we know there's some genetic issues in the family. There's things that don't add up, like changes to speech that are present, or a kid was really successful in a rapid decline, staring spells like I talked about. That's when we kind of go ahead and take these tests. So just something to think about, but we really do want to avoid putting a child through too many workups, because often they're strikingly negative, and kind of a good clinical eval can outweigh this. And I just wanted to list some sites in our city that you can get testing done. I think often this is something that parents run into and feel like is a very closed door. They don't know where to go. Your pediatrician likely has resources. Additionally, if you get anyone who has kind of therapy or mental health in their name in your community, they're going to have some connections and recommendations. Sadly, there's often a wait that can take quite a bit of time to get this accomplished. Just seeing that there's some questions and answers. Okay. So I'm going to get to these towards the end. I don't know if there'll be a recording. I think these are really, really good questions, though. All right, so treatment. We're going to move through this kind of quickly. We're going to talk about medications, behavioral techniques, neurofeedback, the combination, supplements, and dietary changes. There's evidence to some degree for all of these. There's the most evidence for medications, not surprising. We live in a country that really, really does have a structure of medicine. We have an FDA, we have the ability to do studies. You see behind me, we have journals. All these things are evaluated in that way. And the companies who make these medications have them evaluated in that way. On the other hand, some of the neurofeedback, the behavioral technique studies, when they're developed by organizations, they go through their own trials, their own work. But it takes a long time for them to kind of rise up to scientific standard and have that same focus and same attention. So often there's less support in the literature for these, but there's a lot of anecdotal support from people. I'm going to talk a little bit about that as we go through. I will spend a little bit of time on the ADHD medications. And the big thing you need to know is there really are just 3 classes, even though there's a ton of meds. There's like a library of meds, and they have the craziest names. I often joke that some of them are like Harry Potter spells. They just have these absurd names. But when we think about these meds, and we'll get into stimulants, the differences between them often have to do with the ability to dose them liquid, patch, pill, dissolving. Also, can you get it down to 1 milligram difference, 5 milligram difference? Does it last for 3 hours, 6 hours, 8 hours, 10 hours? And that's where the differences are. Not that much in the actual differences between the medications. So we'll talk about that. So it's really important that we get the diagnosis right. It's also important to kind of know that at times we'll be at a decision-making process, and if family's okay with it, these meds are very, very helpful. They last for a number of hours. When we see them work, they work. When they don't work, they don't. And then they wear off and they go away. And so commonly, if we're kind of deciding, there may be some evidence to try the medication to see if it's helpful or not. So stimulants, there's 2 classes. Methylphenidates, you may know Ritalin or Concerta. Amphetamines, you may be familiar with Adderall or Vyvanse, even though there's a ton of other names. Both of these increase the action of dopamine and norepinephrine to kind of get those brain waves moving, and to increase kind of the gating, the ability to focus better and maintain attention. And they raise it more towards kind of a functioning, I don't like the word normal, but kind of a functioning that's more congruent with how we teach and what we expect of people. These have some side effects. They can be really significant. Reduced appetite is commonly the one that undermines care, especially in young kids. Us old people eat for a lot of reasons. We eat because we're hungry. We also eat because the food looks good, because we're bored, because we're social, because we're watching a movie, because we're sitting at our desk. Little kids eat usually because they're hungry, and even then it's sometimes hard to get them to eat. This is something that we really have to watch when we start these meds. We can see weight loss related to them. We can see headaches, stomach pain, and at times some worsening anxiety. In the past, there was a lot of concern about growth delay, and this was something kind of in the 80s and 90s that was felt to be a big deal, but overarchingly has been seen not to be. It used to be that kids were kind of forced to take a vacation from their ADHD meds during the summer out of concern that they could have a delay in growth. That was really hard on some families. Other families, it was not hard. What we see is there might be about a 1/4 inch of difference if you remain on your medication throughout kind of your main growing years in puberty. So if you're going to be a 6'4" person, it may not be as big of a deal. If you're going to be 5'5", it may be a bigger deal. So it's just something to be aware of and discuss with your doctor. Many families worry about kind of stimulants and ADHD. And so I think that this is, let me make sure I'm not. Okay. So stimulants and ADHD and sleep. And so, one second. It's a really wonderful question. You know, I'm stimulating my kid, are they going to be able to get to sleep? Truthfully, for severe ADHD with hyperactivity, there are in fact times that the stimulant is calming for the brain and kids are able to kind of relax and fall asleep. So at times, we will in fact dose these medications prior to bedtime to help support the child or the adult. At other times, the medication does keep kids awake and they struggle to sleep. My son cannot tolerate long-acting medications because he can't sleep. He kind of keeps thinking about things, stays focused, but can't calm down. Other kids, the med wears off, and then they have kind of a rebound hyperactivity, and they can't settle for bed. Doctors, psychiatrists, pediatricians have a lot of strategies to deal with this, but these are kind of the 3 common things that happen. Usually, we'd love to have the medication kind of wearing off before dinner, so hunger is there, and then it kind of allows some time for hyperactivity and everything to wear off. This can be hard on parents because what they're seeing is their kid being hyper and struggling in the way that they thought they were being treated. Sometimes it's really important to make sure you're checking in with teachers to see how the med is working. Okay. So the nice things about stimulants is they work quickly. They work the day you take them. They are not curative. You don't take them for a month and this goes away. They really are, you take them, they treat, they wear off, symptoms come back. For a long time, it was felt that these were weight-based. So if I weigh 100 pounds, I need 1.5 milligrams of medication per kilogram of my weight. What we found is that it's not in fact the case. What in fact the case is people need what they need. This is supported through a lot of research. It's explained well on the Mayo Clinic website. But some kids have a liver that's just revving and they can just burn through these meds. Other people, they kind of slowly move through the body and they don't need as high of a dose. This actually changes a lot as kids kind of age and go up and down. Pre-pubertal kids, as they kind of rev up to grow, we often see they need higher doses, and maybe they even need after puberty, even though they're much smaller than they are when they finish their puberty. And so it really is kind of like figuring it out for the person. When I talk with my patients, I always say the science is figuring out which med works correctly. After that, the art's going to be how do we cover them the best we can to support them throughout their day so they can learn and grow and mature and not make mistakes. And number 2, how can we make sure it's tolerable? And then how do we adjust it over time based on dose? That's why we have those appointments kind of 3-4 times a year, and then kind of then twice a year as kids get older. Sometimes we use booster dosing. Ideally, you would take 1 pill in the morning. It would cover you as long as you need it to be, but then at some point it would wear off and you'd be done. Certain kids, even if they're on a long-acting medication, they may need a med midday to kind of boost them and keep things going. Anxiety, this is really something to monitor because when we're seeing a kid getting really anxious on these meds, it probably means there's an underlying anxiety disorder that we're missing or we're treating incorrectly. Delivery mechanism, these are meds with little kids. Are they delivered liquid? Are they dissolved? You know, can you put them in the vitamin water and can they kind of drink it easily? Is it a patch? There's also some cleverness going on now. There's meds you give at bedtime that kick in 10 hours later. There's kind of some unique things going on. We do sometimes see tics develop over time, and this is something that's pretty personal to the kid. At times, they are quite slight, and it's not something of concern, but sometimes they interrupt learning, sometimes they lead to bullying, sometimes they're just disruptive or they're not tolerable to the family. When that happens, often we do need to stop the medication. And finally, we can see some OCD develop over time as well. With all medications, we talk about side effects, which are common things that are not dangerous but can be problematic. Then we always need to talk about our adverse events. So things that are rare but are dangerous. And so what you're kind of looking at here is that kind of classic ER, kind of like, don't. Many medications can elongate that and potentially cause heart rhythm issues. There is some concern that stimulants can do this for kids. Because of that, they have what's called a black box warning, which in fact sounds really terrifying. To me, that sounds like a plane's crash, and there's like the black box that we find in the ocean, 6 months later. What that really means is in kind of the diagnostic and the physician drug reference, there's just a box around this because they want people to be aware of it. What we found is that these medications have a higher risk of sudden cardiac death in kids that have a predisposition or their own personal history of a cardiac issue. It's been studied a lot. So again, to say that if your child does not have their own personal history and there is not a risk in the family for cardiac rhythm issues, then your child is not at higher risk than the general population. What the American Academy of Pediatrics recommends and the American Academy of Child Adolescent Psychiatry recommends is if there is a history within the family, if there is a history in the child, or if there is concern or you want to be conservative, it's fine to get just a screening EKG. Once we see that the rhythm patterns are normal in your child, it's okay to start the medication. Hallucinations are exceptionally rare with these meds and usually have to do with when we get to too high of a dose. Again, these medications are controlled. They're controlled substances. They're dosed at a specific level for a specific person. At times, when people don't respond to meds, certain doctors will chase higher and higher doses, getting to a point that's kind of beyond normative highs for the meds. And at that point, someone can sometimes start to feel like there's things on their skin and struggle in that way. Then we've talked about tics and OCD. All right, I'm not going to go through all this, but these are all the methylphenidate medications. If you just can kind of look at the top one, Adhensia, which again, totally sounds like a Harry Potter spell. This kind of has to, you can kind of see what the breakdown is. It's an XR, extended release, okay? So it's 20-80, meaning that 20% of it works immediately. It's about a 4-hour medication. The other 80% kind of kicks in slowly and lasts the rest of the day. It lasts for 12 hours. And I say open, meaning you can open up that pill and you can put it, I don't know what you would put it on. We're from Minnesota. You put it in the ranch. I don't know. But it's, you put it in the yogurt for the kid. You can put it in whatever it is. You can put it on an Oreo cookie. So these are kind of the differences between these meds. Next one, Aptensio, again, long-acting, but more kicks in early, and then there's a little bit less later. So there's kind of a bunch of different ways these medications work. Jornay down the page, it's kind of unique. That's the one you give at bedtime, and it kicks in 10 hours later. But truly, these are all methylphenidate. They're all the exact same med, just in very different delivery mechanisms. And so a lot of times it's about finding the right one for your kid. Another one, DexMethylphenidate. This is just kind of a little bit organically different version of methylphenidate. What makes it different, it's a little bit more purified. You need about half the dose, meaning people who benefit from methylphenidate but have side effects can sometimes tolerate this better because you can use a lower dose. Amphetamines, here we go again. Adensis, again, Harry Potter spell, 50-50, 10 to 12 hours, orange flavored. I would like it. Shake bottle, you can kind of shake it in a bottle, whatever it may be. So again, these are all amphetamines. Here we go again, dextro, slightly more purified. Meth, different form. You may be familiar with methamphetamine. This is a controlled version of this that works very well in specific situations. All these meds are controlled. We're going to talk about that in a little bit. Again, mixed amphetamine salts. So these again are just different forms of amphetamines. And this is where we get our longest lasting, often for adults, 14 to 16 hours. Again, just different forms of the same medication delivered in different ways. What we do find, though, is this delivery mechanism can sometimes really kind of change how people do. So Adderall, many of you are probably familiar with this, it has a nickname of Angerol, or it kind of makes people angry or irritable. Commonly what we see is it has to do with they kind of take it, it stops working abruptly, and kids are kind of left kind of feeling emotionally out of control, busy, these symptoms kick back in. Vyvanse, the one on your screen, this is one that sometimes people seem to tolerate better when they need an amphetamine. Why? Slow on and slow off. Because of that, people kind of don't have that kind of rebound. That rebound is really common when we first start these meds, to the point that I kind of talk about, maybe give your first couple pills at the weekend, not for school, so you can get an idea when it's working. So when your kid comes home after their first day on their stimulant, they may feel a little out of control. All right, oofta. I'm going to take a drink real quick. All right. These meds are DEA controlled. I don't know where it is. I have a little key fob. When I prescribe this, I need to sign my name. Then I hit my key fob. It gives me a unique number every single time different that I log in that tells them it's me who's actually prescribing it. There is potential for abuse. There is potential for diversion. These are popular drugs both for partying and sometimes at colleges they have resale value. It's really important that these meds are, if you're getting them, that you're taking them just to the patient, one prescriber. You can prescribe them 1 month or at times 3 months. However, these meds are very safe when prescribed in a controlled way, and they're strikingly helpful. These meds are purified. There's not a risk that they're getting an odd dose or there's other things in them. But it is something where your doctor can stop prescribing if they're not used as expected. So I think it's something to keep in mind. So a huge question families have, an appropriate question they have, a valuable question and a thoughtful question is, if my child starts on these, are they going to crave meth when they're older? Are they going to crave cocaine? Are they going to crave alcohol? Am I setting them up to be dependent on a stimulant and therefore be dependent on other substances as they get older? And kind of as we evaluate this over time, studies after study after study shows that there's no evidence that stimulant treatment is associated with worsening of substance abuse in adolescence. In addition, in adults with substance abuse and ADHD, which as we talked about before, there's a huge risk of substance abuse if you have ADHD. Treatment with a stimulant can help prevent worsening and improve the substance abuse related issues. Finally, there's numerous studies suggesting that there's a potential and significant protective quality against kind of developing that. And we really think about this trajectory children are on, and that over time, if they're too impulsive or they can't pay attention, they start to get off their trajectory. They start losing their ability to use their skills and to grow and reach their kind of goals in maturation as adult. So we do see that these are very, very helpful and do not put kids at risk. On the other hand, untreated ADHD, due to the inability to think things through at times, the impulsiveness, the desire to slow things down themselves because they can't pay attention, we see risks for earlier use. We know that poor school performance is a risk factor for substance abuse. And we do see that in families with substance abuse issues, there's often comorbid and untreated ADHD. So I'm trying to make an argument here that stimulants are safe, they're effective, and they prevent these issues. But I do think if you're concerned about it, talk to your doctor. It is okay to ask these questions, and it's okay to be thoughtful and think them through. Okay, moving along. We talked about a lot of stimulants, a lot of Harry Potter type medications. The other medications we use are non-stimulants. These are often less effective, and these are often what we use after we determine stimulants don't work, but at times we find that these are more helpful or more indicated. Many of you have probably heard of atomoxetine. The other name for it is Strattera. Strattera was developed to be an antidepressant, and turned out it didn't work well for that. But because it increased norepinephrine levels, remember we talked about that before, it really seemed to help people with inattentive type ADHD the most. Some hyperactivity, but really that inattentive type. It takes time to work. It's similar to the antidepressants, 4 to 6 weeks. We got to give it time. You got to take it every day. Unlike the stimulants, this isn't one that you can kind of take breaks from when need be. Interestingly, in people under 25, this similarly has that 4% suicidal thought risk. No increased risk of attempts, completions, but there is that risk of thoughts similar to antidepressants. You see that again with Wellbutrin, the med underneath it. This is something that sometimes gets missed when pediatricians start these meds because they're so familiar with them being for ADHD and not for depression. Wellbutrin is another medication. Commonly, this will get started when someone's struggling with depression and ADHD. This one is primarily dopaminergic, which means it enhances dopamine activities. Again, we talked about that before, the other kind of neurotransmitter that has to do with attention, functioning, and kind of gating. Again, this one has a suicidal ideation risk. These meds can be used with stimulants at times or to lower the full dose of stimulant, but commonly they're not used in that way. These medications, on the other hand, are. Okay, so these are old blood pressure meds that rarely get used to just treat blood pressure because they're sometimes hard to tolerate for that reason, especially the clonidine. What we see is that these medications can be used with a stimulant or used alone and sometimes get to that behavioral issue a bit more or the anxiety a bit more when it's comorbid. So clonidine, old blood pressure med, is very sedating. And the issue with it is that it needs to be given a couple times a day, usually 3 to 4 times a day. And while your child may not be hyperactive anymore, they also may not be awake. And while they're not disruptive, they're also not learning, maturing, growing, staying on their trajectory, which is our goal, which is not the goal here. Where clonidine can often be quite useful is it's kind of a off-label sleep aid for those kids who really can't settle down at night. And it can help them calm their brain, calm their body, and start sleep at a very low dose. Guanfacine is kind of the cousin of clonidine, but much less sedating. And what we've seen is it's really nice because when you combine it with other stimulants, you can sometimes use a lower dose of the stimulant, number one, or you can get more benefit out of the dose, number two. It also can help with kids who've had significant trauma. It seems to block some of that fight or flight reflex that those kids have. And commonly kids with like ARND, that alcohol-related neurodevelopmental issues, can benefit from that combination. We also have a lot of nice studies looking at brain waves when guanfacine, another name for it's Intuitive or 10x, is combined with these meds, that there is kind of a nice cumulative effect. Finally, nortriptyline. This is something that I think is on my slide from educating other doctors. That is a really nice med when you have a lot of OCD and a lot of ADHD, but it's very complex, and so we don't need to belabor it here too much. All right, pharmacogenomics. This is what we want to have happen. This is what I would dream to have happen, and sadly, this is not ready for prime time yet. I was given this pamphlet by Castle Medical, and kind of this idea that the right drug for the right patient, the right dose at the first time. So when this works, they come in, you do a little swab, you send off the DNA, and we get kind of this assay of information that has to do with number one, how do you metabolize this med? Are you someone who breaks it down super fast and you need like a second dose during the day? Are you someone who breaks it down really slowly and maybe we need to use a lower dose because it just hangs around? Additionally, there's some genes we know of that have to do with how medications work. Example would be the serotonin transporter gene. When we think of some of our SSRIs and how they work for depression, that gene is really important. And if you don't have part of that gene on your genome, that's a big deal. Like that med may not work. In children, we've seen that this is just not ready for prime time. By children, I mean that kind of child to young adult brain up until really like 23, 24. And the way I really know this, the way I kind of understand it is when I go to conferences, or when I used to before 2020, none of the pharmacogenomic companies are present at all at the child conferences, and they're present throughout the adult conferences. And what we see is there's continued evidence that this can be helpful and effective in adults in guiding care. It is not definitive, but it is helpful. But in children, it's really not. So we have to rely on our understanding of population medication and the studies that have been done, as well as the individual needs of the child. And your doctor can help you make kind of a good informed decision balancing those two. The other part is, for a long time, there was an assay that was used for the ADHD meds, looking at how they were broken down, so the stimulants and the non-stimulants. And sadly, it turned out that that assay was not congruent with clinical outcomes. And so it has been removed, as far as I know, from, I think, all of these tests, which is a really big thing, because for a while, you'd get this test, you'd look at it, you say, oh my goodness, we can't use the amphetamine class for you because of this issue with your genetics. And what we see is that clinical outcome's not right. This really entered about 10 years ago, I want to say, and some people are still very dependent on it. I think it's okay to collect as kind of a framework and something to guide and have understanding, but it should never rule out any medication. It just may guide kind of how you use it. I have nothing to do with this company, but I really, really like them. AttitudeMag.com, this ultimate guide to ADHD med. I think you'll read a lot of the things I'm saying. What I like about it is it kind of boils things down for families to understand what your doctor's thinking. Why did they just jump from 36 of concerted to 54? Why did they add a booster at the end of the day? Why are they talking about magnesium? Why are they talking about neurofeedback? Why do they want to do the testing again? So I think this is really nice. I'd strongly recommend it as a guide for families. Let's see what time we have. Oh, we're doing great. Good. All right, go Hawks. All right, non-pharmacologic options. So I think this is really important. There are non-pharmacologic options. There is efforts being made to build more of these. Stimulants have drawbacks. If you have a picky eating kid with ADHD and you put them on a stimulant, it is one of the hardest things in the world to not watch your kid eat. Some people just don't want to use a stimulant. They don't like the idea of it. We need to have other options than just these meds. So I'm going to talk about them, but I just want to point out some things. Most of these studies are limited to less than 50 subjects. All of these are case reports, meaning doctors watch what happened, they provide information. However, it's not, if you remember, high school stats or college stats, it's not random control. It's not double-blinded. And we're seeing that some of these studies don't build out when we try and do them in those larger studies. However, there's not been enough of those larger studies to say this doesn't work. Finally, when we look at some of the non-pharmacologic options, many of them are based on business models. And I don't mean the supplements, but I mean some of the like brain balance and other things like that. There's nothing wrong with that. And these can be incredibly valuable, but at times they can also be expensive. And there may not be the same drive to kind of make sure there's a purity of just treatment. However, many people do find them useful. So supplements, fish oil, boom. And then this is a good, from this ADHD Med Calc, there's a very nice supplement guide if you'd like to use it. So there's a lot of anecdotal evidence here. And if you go on Amazon and you look at the studies that work, I'm sorry, I'm getting distracted. I may have my own issues with attention, my apologies. It's really hard to lecture, by the way, just looking at a little image of yourself. I don't know if anyone else has had to do this, but it's really different. I hope next year we can do this in person and kind of have some give and take. But anyway, there's a great load of ADHD type Amazon endorsed products where parents write the most wonderful things of how it's helped them, of how it's helped their children, of how it and everything, but that's not a study, although it's really convincing. I mean, we all know we've bought Amazon products purely because of how people endorse them. When you go to the page and you look up like Super Calm or ADHD supplements, it is unbelievable the amount of things that come up. Many of them have a few of the things we're going to talk about, but I really want to stress kind of the things that we know work. So fish oil, the 3,6,9 or 3,6 fatty acids have shown a lot of evidence in treating mild ADHD. And at times that means kind of ADHD after puberty, where people are developing, they've developed skills, they've developed wisdom, it doesn't affect them as much. Or for people who are stimulant sensitive, so somebody who maybe needs 30 milligrams of Ritalin, this can maybe get them down to 20. And this can really be a huge thing for people who are struggling with the high dose stimulants and some of the side effects like headaches, upset stomach, inability to eat. Notice I'm not saying this is a great replacement for kind of a more severe ADHD or a kid who's really struggling with hyperactivity. However, it really can help bring those doses down. And so it's something to think about. Puritan Pride is a good one, and it does have that 3,6,9. The studies have shown it's not just omega-3s, it's the 3,6,9. The 1 to 2 grams per day, 1 gram is often used for under 16 and 2 grams above 16. And fish oils really do have some good supports in other ways. A trick you should know about if you do consider this for a child or for yourself, if you freeze the pills, often you get less of the upset stomach and you get less of the potential for that fishy taste in burps. So many people will freeze these pills. Other things that are evidence-based, so magnesium. We try to avoid citrate. It seems to upset the stomach and cause diarrhea. Usually like 200 milligrams daily or 200 milligrams twice a day is calming. And that calming can help with some of the physical kind of restlessness, busyness, having that motor going, not stopping. So sometimes added to a stimulant or used alone in certain circumstances can be really helpful. It can often decrease anxiety as well. It's fared much better than placebo, so there is evidence for it. And so I'd consider this as well. And I do use this in a lot of patients when we're trying to lower their stimulant load. We've kind of reached a dose that's tolerable, and we want to kind of see if we can get more benefit, especially for busyness of body. Zinc also carries some evidence as being better than placebo. And then ginkgo, which you kind of think of as a memory enhancer, a focus enhancer, executive functioning enhancer. The studies really show that it's helpful with methylphenidate. There's not any studies showing that kind of it works well on its own in treatment of ADHD. All right, so the studies that kind of don't show evidence but are things that people use, these are often things that are on these kind of neuro health or other stuff or calming, whatever. These are kind of the things that get added. So kind of star vitamin D, there's been a lot of studies looking at activated D. There's been a lot of doctors who even will say, like, if we have the right D levels, they're really important. I agree with that. There's been a lot of studies showing that kids on inpatient units have lower D than other kids, inpatient psychiatric units. But what we've seen is that the supplementation of vitamin D, while it helps energy, it does not appear to help mental health issues. So it is important. It helps our energy, it helps our immune system, it helps us avoid osteoporosis when we're old by building nice, strong bones. In Minnesota, we need it because our sun is so weak from like October to April that we can't kind of get it from the sun. We should not be getting it from tanning booths. We should just be getting it from a supplement. So I really recommend a D supplement, but there's not evidence for ADHD. And then kind of no studies really did compare these non-pharmaceutical options to each other. In studies where they compared them to stimulants, none of them work as well as stimulants, but there are studies showing benefit when combined. So on the other hand, so when we think about it, it'd be really easy in life if everything was solved by a pill, but sometimes when we put the work in, we can really see improvement. And so for our inattentive kids, neurofeedback, which is kind of placing a few dots on the head and kind of having them pay attention and do tasks, kind of and train their brain, we can see benefits from this. We can see potential long-lasting benefits. Some schools have this available, some sites have this available, but it's kind of probably one of the most supported areas for treating ADHD. You may hear it called QEEG, which is kind of the way they measure. You can see in this picture kind of that increase in kind of attentional focus. So you kind of go from, again, those low frequency to higher frequency waves. You go from the delta to the higher frequency waves. There's a lot of anecdotal evidence with this, but some of the issues are, we don't really know like what the standard treatment is. So many providers who give it have their standardized treatment, but there's not one that's like recognized by medicine. So I think of kind of like many different areas when we're, we know what the steps are. You do this, you do this, you do this. Okay, this is the response. Then we need to do 10 more treatments. It's unregulated. We don't really know the answer. The other part is it seems like attention improves, but often the ADHD behaviors don't as much. And we do have to watch kind of commercialism, as this is often expensive. And I kind of joke that sometimes these ADHD treatments are a little bit like, mascara commercials. Like every time you see a new mascara commercial, it's like, Olay, major breakthrough in mascara. And I'm going, how many mascara breakthroughs can we have? I think that can sometimes happen with some of these treatments. On the other hand, I do think neurofeedback and then cognitive training, which I'm going to be talking about, really do show some evidence that they can be useful. The concern is if a child is spending 5 hours a week doing that, we want the benefits to last, but are they also not getting the benefit of a tutor or support in school or refocusing on their schoolwork? This is a parenting decision. These are gray areas, but they're things to think about. So brain training, to quote, transforms science into delightful games. So I think I'm old enough that I remember kind of like the old like Game Boy 3DS and before that. And there was actually a lot of brain training games that got really popular. There was somewhere like there was a key, you had to like tap where the key was, and you had to remember 2 keys were 3 keys. If any of you have ever played these, they do show that you can kind of have some improvement in attention, in working memory, and in focus. However, sometimes it seems like it only improves for the game, and it may not generalize in a greater way. There's really a push to make these generalize. And we see in other conditions like schizophrenia that cognitive rehabilitation is really useful. I apologize, by the way, this appears to be the German CogMed slide. So this is like, here's the games, right? And you can go, all right, I'm gonna go do the Radio Billarna, which is bumper cars. And then you play a little game that helps you build your working memory and hold things in your brain longer. At times though, this doesn't seem to generalize in the methodology that one would want it to. You get really good at the games or playing the games in their way, but it doesn't seem to help schoolwork. Interactive metronomes, this is the idea of kind of using a beat while you're reading, while you're paying attention, to build focus, to kind of distract the brain in this physical way, to kind of build out focus and skills. There is some evidence that this is effective. The studies remain small, but the results are good. And sometimes schools have this available. Some of the bigger conglomerates, so like Learning RX, Brain Balance, and other things. So these can be incredibly worthwhile and incredibly helpful. They can be incredibly expensive. But in certain families and in certain cases, they can work well. It is a way to focus on your child's learning and your child's care. The reviews for this, when I look through it, are mostly internal. They do have that review board, but it's internal, and they claim effects. They have not been kind of studied externally yet. And there has been lawsuits filed by the Federal Trade Commission because they're kind of saying that we can increase your IQ. That's not been shown to happen. And then the costs for these can be significant, and they're commonly not covered by insurance. I think at times what schools do really well when they kind of look into a kid is trying to figure out how they learn, what helps them learn, what helps them focus, what helps them be successful. Do they just need a couple rubber bands around there at the bottom of their chair? Do they need a seat they can rock in? Do they need a stand? Do they need someone to remind them? Do they need more time? And I think kind of finding that individualized skill set for each kid often can be really useful, and then they can then practice that in school when they're doing their actual learning versus having a lot of time outside of school trying to learn how to learn. I think if you have the ability to do these, they can kind of refocus a child and be helpful. I think it's just something to keep an eye on. So behavioral treatment. With ADHD, behavioral issues come up. the reminders, the forgetfulness, the impulsiveness, the intrusion. And kind of across my field, regardless of the condition, not just ADHD, I always kind of think of like every parent has their own intuitive parenting, and it may cover 95% of kids. But at times there's going to be those outlier kids where our intuitive skills, no matter how robust and significant they may be, they're just a miss. You kind of have the kid that doesn't fit your skills. And what parent training and child-focused treatments do is trying to help you kind of build on your own skills to help this child that may be less intuitive to you. And so I think these are really strong interventions. Finally, family treatment. So this is like the standardized therapy that's used for the treatment of ADHD. It is not endless, but it does take some time. But really, these are the goals, to try and find ways to kind of understand your child's ADHD. Is it inattentive? Is it hyper? What is it? Learn to attend more carefully to their misbehavior, but also focus on when they're doing well and when they're complying. Having a home token economy. I mean, many of us have this when we're toilet training our kids. I remember the little rubber toys that I would get when I was a little kid. For my kids, they got Lego minifigs when they kind of learned, but that's a token economy. That's their kind of earning something for doing the activity, or they can earn like a token and then at a certain point trade it in and get something bigger. And so it kind of helping them with like a positive reinforcement schedule. We kind of train families how to use a timeout effectively. As weird as that sounds, these get tossed around. Kids with ADHD need a reliable and consistent environment. Reliability means they kind of know what to expect when they demonstrate a behavior, whether good or bad. And consistent means that it's the same thing every time. And so we really want to build towards that so kids kind of can start to make their own decisions versus like, well, on Monday nights, if I don't do my homework, I get yelled at. But on Thursday nights, because it's the end of the week, I can get away with anything. And so it's kind of like it's different every time. Those school report cards, I imagine some of you fill these out. I imagine some of you get them at the end of the day. They're really helpful in creating communication that's effective between families and children. And then kind of being aware of the future misconduct risks that can happen that we talked about, how to stay ahead of that. Dietary. This is an area that actually there's some support for. So having a good nutritious diet. So kids with ADHD benefit from kind of a more whole food or simple diet. High protein, complex carbohydrates, and then avoiding kind of white foods and simple carbohydrates. If you're able to do this for your kid, that's wonderful. I recognize that simple carbohydrates and are kids want them, they crave them. They're also inexpensive, and some families cannot afford to kind of give a high protein diet. But what we see is these foods that break down more slowly and hold more slowly often help with attention. Supplementations like we talked about. Many families will also want to focus on elimination diets and kind of gut health as a mechanism to kind of treat this. What we see is that artificial colors, yellow and red, can be problematic. Additives can be problematic. The American Academy of Pediatrics supports those elimination diets. There has not been support for a sugar elimination diet in kids. At times, pediatricians feel really comfortable walking through some elimination diets. I would also just say that if you're already struggling significantly with behavior, and then you try to eliminate 3 different parts of someone's diet, and that becomes another argument on a regular basis, it may lead to more crisis than benefit. So I think, again, balancing what works within your family and working with your doctor to understand it. All right, so this is just kind of cool. Endeavor RX is the first prescribed video game ever. I have not yet prescribed it. I'm trying to figure out how to do it. But it's an FDA-approved ADHD treatment, really targets just attention, not hyperactivity. You complete missions, and the whole deal with this is to teach the brain to multitask and do many things at once. And it learns from the user over time and builds upon it. And there's actually been support that this can be effective as a non-medical, kind of a non-medication treatment. So I think this is something to really consider in the future. All right. There's a lot of other treatment modalities. These are ones that are not supported from my review in the literature. So I think it's important that if you're going to start something, even, yeast infection treatments, auditory stimulation, some of these other things. And I apologize, I need to get metronome treatment off there. There is support for that. Making sure that number one, they do no harm. Number two, they're affordable. Number three, the time spent, the money spent, you spent better with a tutor who's sensitive and can help you teach your kid to learn and kind of figure out what they need to learn. All right, CPT. I didn't mention this before. CPT, I once told a kid, hey, we're going to do a computer game. And the computer game is going to help me know if you have ADHD. Kid does this, and they turn to me and they go, hey, Stein, that's a computer program. That's definitely not a game. And the truth is, that's what it is. The CPT is a very structured assessment where your child looks at a screen for a long time, and it flashes letters at them. A, D, G, L, B, X, X, D, X. When there's any letter that's not an X, they hit the space bar. When there's an X, they don't. The monotony, the duration leads to errors. Errors where they hit the space bar inappropriately, where they don't, where they forget to, where they stop paying attention. What can be kind of nice is when you start treatment, you can get this before, which can help with your diagnosis. You start the treatment, and then subsequently you can repeat this and see if there's improvement. It's something that we use a lot in our level of care at partial hospital and inpatient as a way to check, hey, does this med seem to be making a difference? As parents, because these meds wear off, it may be kind of hard to check in on what's happening. It's good to hear from teachers. Also, sometimes inviting grandma and grandpa back. I know right now that's a little bit more difficult, but maybe through a Zoom session or something, but checking in with them, checking in with family, checking in with friends, and just saying, hey, have you noticed any differences in little Johnny of late? And that can be really helpful. Your doctor will ask you some really structured questions to get an idea. Often parents notice really quickly when this is working. All right, a question I get all the time. Hey, but my kid has ADHD, but they can sit and play Minecraft and Roblox and Fortnite and then Among Us and all these other games for hours. I don't get it. What I say is video games really can lead to, they really are almost like a casino pull for kids. There's so many short rewards. There's so many short quests. There's so much going on. They're so quick. They can almost intoxicate the brain of kids with ADHD. We got to watch this. And it's important because over time, kids can really get stuck on these games. Kids can have issues with withdrawal from video games. I don't know if any of you, I've experienced in my home where if a kid plays too long and you kind of stop them, they're irritable, they're grumpy. They often feel like they need more video games. They develop a tolerance. We're kind of really looking at this as an individual condition. But being able to play video games for hours is not indicative of not having ADHD. In fact, it's kind of like soothing to the ADHD brain. Okay, so we've been through a lot. I clearly see there's questions. I'm going to get to them. I just want to mention this. This is that pediatrician consult line. If your pediatrician ever has questions, this is something by the Minnesota Department of Human Services that I'm a part of and other doctors and social workers are a part of, where your doctor can call in and kind of say, hey, I'm with little Johnny. We tried the Ritalin. We're at 10. I need some help getting the next step evaluated, or I have questions about this, or they're going to go see a child psychiatrist and do testing, but it's 6 months out. What should I do next? And it's a way for your doc to kind of call in, check in, and go from there. Another resource I want families to know about is Fast Tracker. If you ever are looking for a mental health program, a psychiatrist, anything like that for your child, or for yourself, whatever it may be, this is an updated database. And I think our field is particularly poor at kind of having open doors. It's very easy to find a pediatrician. It can be harder to find a psychiatrist. And so this is a way to find the care you need. You put in your insurance, you put in your location, you find out what's available, and you call them quickly. I'll send these slides out later, but these are just some of the books that I'd recommend. The Gift of ADHD, I think, is a really strong one. ADHD kids are incredibly talented. They're incredibly bright. They connect dots that other people do not connect at all. And they have great abilities. Kids with ADHD can have very high IQs. They can be very successful. They can end up being almost anything. And I know lots of incredibly successful people and children I've cared for with ADHD who work on Wall Street, who are physicians. I've had the luxury now of being in my career long enough to watch kids go from being 13 to being 25. And it is not a death sentence. It does not mean anything's wrong. Circling back to that idea of neurodiversity, there's this idea like there's a lot of different brains. And again, our systems are doing a better job of holding more of those brains and being successful in supporting that. But ADHD and severe ADHD at times falls out of that. And the treatment can really be helpful to be protective and help kids stay on their course. A couple online resources. Again, at that bottom, the Attitude Mag, I think, is really good. So in conclusion, it's really common. It's very treatable. Getting the diagnosis is really important because especially when meds are not working, that's when we run into a lot of issues. Supplements can often supplement meds really well, but may not do enough for certain kids on their own. The stimulants are usually really well tolerated when dosed appropriately. There's really reliable methods to monitor. And then treatment awareness, whether it's just through family support and IEP educational support, or it's through medications, really helps protect your child's kind of trajectory, that they stay on it, that they achieve what they're meant to achieve, that they don't get sidelined, they don't struggle. And I think this is a really important thing. So I appreciate your time. I'm going to stop sharing my page. Stop share. Okay. And then I'm going to see with the chat, the questions. Okay. And I will do my best here, guys. So at 6 o'clock, someone asked, my child was just diagnosed with ADHD. And reading up on this stuff, it really seems likely that I, the parent, have it too. What is the path to diagnosis for an adult? Is it worth it to be diagnosed as an adult? Okay. So we all have aspects of it. So first off, that depends. But in mental health in general, we all have aspects of anxiety. We all get anxious. I was anxious before I did this presentation. We all have periods of sadness, of worthlessness, of depression. It is when there is morbidity, loss of functioning, that this becomes problematic and treatment is warranted. Just because you have aspects of OCD, if it's not inhibiting your success and joy in life, or it's not to a degree that it's really negatively affecting you, it does not warrant treatment. However, if you're an adult and you're feeling that you're not as successful at your job, or you're spending excessive time that's interrupting your family time to stay organized and productive, then I think very much it's worth investigating that. And I think an easy place to start is with the doctor that you work with, your internal medicine provider, to talk through it. So I think that, yes, it may be worthwhile, but also if you're adult and you're in advertising, or you're a physician and you use your creativeness and the ADHD and it keeps you going and it's not a problem, I don't know. Maybe also ask your spouse or partner. Maybe they'll have an opinion as well. You don't know. So the idea of an underactive brain, how do you reconcile that an underactive brain with a person who has ADHD but is intellectually gifted? I kind of hope I explained this, but ADHD does not equal IQ. ADHD is just difficulty with kind of maybe putting that IQ to work for them, at least in the way that we teach and that we're structured right now. So you can be very, very bright but still have ADHD. You can be very, very bright but be hyper and not be able to sit still throughout your class time. The underactive brain has to do with some of the ways that your frontal lobes can kind of inhibit and process information. So it's not that you have an underachieving brain, it's that it's just the area that controls kind of the inattentive and attention symptoms is less so. How has distance learning changed the way kids are diagnosed these days if schools can't always report on behavior because the child is at home? Yeah, that's a really good question. I would say that, all right. So first off, I think that we are all struggling more. We are all having a harder time. As I talked about before, that Bronfenbrenner slide of you being in the middle, but all those other parts make up who you are and how you function and your success and your path and your trajectory. And right now we are in a time where many of those formal frameworks and structures that keep us on task and help us grow and pay attention are gone. I think that your feedback from the teacher is helpful. I think your doctor will help you evaluate it. I think right now there's probably more kids being diagnosed with ADHD, but it also may be kids that had the pillars and the structure and the four walls of school and the engagement and a teacher who can lean over them and pay attention, and the parent in the classroom is present to support the class, and all those other things. When they're home and they're distance learning, they lose some of that maybe engage their brain differently. So it may be that would be a good kid to try the fish oil, or a good kid for a short period with a stimulant, and then reevaluating kind of when they do go back to school. I think it's quite fair to say this is a certain point of time. It warrants support and treatment. But again, we need to reevaluate when our structures are in place. Again, also, we kind of worry about that morbidity issue. How severe is the morbidity in the home environment? I think there will be a video recording of this. I don't know the answer of that. The next question, how do you know for sure if a med is not working? So I think you can repeat the CPT. You can repeat the collection of information. I think that sometimes, again, it's kind of getting information within the family. Often meds don't work because they're intolerable, and we stop them because there's headaches or stomach aches. At times we reach doses, like a Vyvanse 50 or 60 or 70, and we're just seeing like a partial benefit. It would point to maybe a different trial. Usually what we see is a recurrence of symptoms and a recurrence of significant issues in kind of the day-to-day functioning. And usually the med never works, or the med over time works less than it used to, and it speaks to kind of a more rapid metabolism and a need to go to a higher dose. Are there any considerations to use medications in children who have developing brains versus waiting until their brains are fully developed? So Amy, Anonymous, I think that's a really good question. The brain is fully, so when we think of a child's brain, it is, how do I put this? It is like a tree with thousands and thousands of branches and leaves. On the other hand, a brain that is fully grown and matured has gone through apoptosis, which is this kind of scheduled cell death, where you get rid of all the neurons you don't need. So I kind of think of the child's brain, we know this from lots and lots of studies, has all these neurons, more than you'll ever need. And over time, you get rid of the ones you don't. And then by 25, you're an adult brain. I think the issue is if we wait too long to treat for kids that have severe illness, we can set them on a path or a trajectory where they've already adopted some really negative behaviors, skills. And if we wait until someone's 18, 19, 20, they've written a very large chapter in their lives. We continue to see, despite these meds being used for generations now, that they're effective and they're helpful. At times, people, you are quite right, develop out of this, and they do not need these as an adult. Or they need them in certain settings, but they don't need them in the same way. Or they become a certain career that allows their ADHD to be a strength and that neurodiversity to be a talent. And again, I think this circles back to the level of morbidity and dysfunction and risk that is in your child's life. It's a very individual decision, even though we have all this population medicine. Would a genetic test help my kid's provider with dosing? I saw one online, like 1 ohm. I do not use them, nor do I know other child psychiatrists who usually use them in their treatment. So I'll keep an eye on that. How do supplements help kids who have ADHD and anxiety issues? So there's some overlap. Magnesium is one that can help both. Inositol is another one that's helpful for anxiety. And at times they can lower the dose of the ADHD med. I think that's something really closely to watch, because sometimes we are misdiagnosing ADHD when there's in fact just anxiety. We need to stay on top of that. So again, I think I talked about that differential, but it's hard. Are there tips or tricks for school personnel to try and differentiate between ADHD and trauma and then work with those students and parents? I think that's a really hard question for a short answer, but there are a lot of things that help us understand this. There's certain behaviors that are evidence of trauma. And ADHD, while you may be more impulsive, it doesn't make you more prone to some of these behaviors. Also having a history of trauma. Commonly, kids with trauma and ADHD benefit more from adding Antunev because of how it affects the fight or flight reflex. I also think trauma reactions like hiding under chairs, hiding under desks, running from people, some of the diagnostic symptoms of PTSD help us understand that. But that is tricky, and I think it kind of warrants its own lecture. Any advice for how to help newly managed diagnosed 17-year-old who will go off to college in a few months? We're still trying to figure out the right treatment. I'm nervous we're running out of time before college in September. So I think that's a really good question. The nice thing about stimulants, if you're leaning into those, is that they work quickly, and you can kind of almost do like a weekly treatment as you build towards college. The other thing is colleges usually have a fairly significant and robust mental health resource, and so your child can continue that process. Usually, we find that most kids respond to both amphetamines and methylphenidates, but occasionally they respond to only one or the other. So I think that the goal is to determine, hey, is my kid going to be like methylphenidate, or are they going to be amphetamine? Usually docs start at a methylphenidate first because they're a little bit better tolerated. If that's the case, getting up to the right dose. And I think kind of using the time in school to help figure that out. But I also think the driving in your 17-year-old, the preparation, your observation of their behaviors, how they're feeling with it. Many older kids can kind of feel these meds kick in. They can feel more organized and focused. They can kind of give you that feedback too. And I think it'd be okay to press the doctor to say, hey, she's going off to college really shortly. Can we meet every couple of weeks until we get this figured out? Do you often see learning disabilities with ADHD diagnoses? Is there a connection? Our son has recently been diagnosed with mild ADHD and also decoding learning disability from neuropsych testing. Currently, we are focused on non-medical solutions. Yeah, I think there's an overlap that we can see learning disabilities tied to ADHD. And I think that's often, the thing that I think sometimes we see kids diagnosed kind of rapidly with ADHD and the learning disabilities get misdiagnosed. I think it's okay to lean into non-medical options for a period of time. And then that may help you determine what is an appropriate time to start medical options if need be, if ever needed. And so, yes, we do see overlap there. What type of careers would allow my child to use their ADHD as a strength? So I think almost any career, truly, but it has to have aspects of being rapidly moving, engaging in a lot, but they're going to have to learn some of the organizational skills. Often they're careers that, there's creativity or kind of rapid thinking involved, a lot of the creative arts and other things like that. But, attorneys have ADHD, physicians, entrepreneurs have ADHD, people in sales have ADHD. It really depends. And some of these people use meds, some of them don't. So I think it's really, I think the world's wide open for them. And I think that it's kind of what their interest is, and then figuring out, do they need treatment to maintain that interest or not? And I think that depends on the situation. Final question I have here. 2 of my 3 children are on ADHD meds. They're not as free-spirited as they used to be. Yeah. It's almost like the meds crush their funny, smiley bones, if that makes any sense. It does. It does. And when these meds blunt kids, it's not great. And it feels really awful. And when you see the kids kind of losing that ability, things that can sometimes cause that are when the dose is too high. And so at times when we see hey, yeah, my kid's super focused and they're doing well in school, but they're just kind of hi, mom, hi, dad, they're sullen, they're different. I think that's a time to kind of reevaluate. Can we go to a lower dose and use an omega-369 fatty acid? Can we use magnesium with that to try and get our dose effectively higher? Can we go down from Adderall 30 to like Adderall 15 and add guanfacine and see if we can balance things out in a better way. So, I absolutely know what you're talking about. I think I would talk to your physician and see if there's methods to balance that. Med vacations can be helpful as well. Just so you know, med vacations are methods of kind of taking a break on the weekends or taking a break during the summer or breaks. At times with younger kids, that's harder. So it's something that we can work with. I think that's a wrap. We kind of went a little long. I appreciate everyone's patience.
We had a couple questions that found their way into the chat. So let me just sum those up really quick. Okay, so one is a grandparent wondering if there's a way that they can alert a therapist to a mother's drinking during pregnancy if she's unwilling to share it.
Yeah, so first off, I think a lot of people worry about HIPAA laws and the protection, like they can't share information to me. That doesn't stop us from sharing information of concern. So as somebody in the community, you can always call a doctor and they will say, I can't confirm or deny that that's a patient. I can't confirm or deny they're in the hospital. You can say, yeah, I don't care. I just want to provide you that I'm concerned about the well-being of this child, the well-being of this parent, whatever it may be. And I think that is always okay. And I think that's always really valuable. And so while the doctor can't share information with you, you can always share information with a therapist or doctor in that way. So I think that's worthwhile.
Great. And then one more, what is the next step in the path of a child who's been diagnosed, tried supplements, clean diet, has been medicated for several years and still really struggling every day, in trouble at school, executive functioning and organization, conflict at home? They do see a psych at PrairieCare every month, but insurance doesn't cover further treatment, and they attend a private school where there's no help available. So any other ideas for resources?
Yeah, so at times when your insurance will not cover, potentially looking at case management and then shifting the child's insurance to MA, because our MA or our state insurance, and I don't know exactly what I'm talking. This is where the social workers are so helpful, and I'm not a social worker, but at times that's a methodology to get care that's not being covered for children and families. I think also, I would press your psychiatrist, and if they don't have good answers for you, then asking them to lean in. And, I work at Prairie, and it's amazing that we have a clinician list and that the questions we get, I'm like someone emails, I'm looking for a therapist for a deaf patient and their family who can speak American Sign Language, and 6 people send therapists. There's also been some changes with this. And one of the nice changes, one of the very few nice changes of COVID is that this video health is huge. And so at times you can now see people who aren't in your immediate area, whether they're at the university or whether they're up north or whether you're up north or you're down, you're in Chan and people in Brooklyn Park, whatever it is, or Woodbury, you can maybe see somebody who's more specialized and can help you revisit. I think the other thing is, and this is really hard, but growth is so valuable. And there was a very wise question about kind of the developing brain. The good news is if we can keep kids safe, if we can keep the bumpers on the lanes and keep them going in a certain direction to a degree, usually the growth is really helpful. And that wisdom is that they get from learning and growing and practicing becomes almost a treatment on its own. So, yeah. Questions?
I think we're good.
My goodness, thank you everybody who hung on to the bitter end. Let's see, go Storm, go Hawks, go Arts. And I wish you guys all well, and to the parents who are here, you guys have endured an incredible year, in a year that it will become legendary, I would imagine. And we are nearing the end of it, and I wish you and your family well, and good health and good mental health and all of that. So thank you very much.
Yes, thank you, Dr. Stein, for coming to our webinar today and sharing all your expertise with us. Really appreciate it.
You're welcome.